Welcome to the Breakfast Symposium entitled Elevating Transplant Care by Combining Molecular Diagnostics and Artificial Intelligence, sponsored by CareDx. On behalf of the AST, I'd like to thank CareDx for their continued support of the CEoT meeting and for AST in general. So I'd like to welcome the symposium moderator, Dr. Nikhil Agarwal, who is a transplant nephrologist but is a senior medical director of kidney transplant for CareDx, to the stage. Thank you.
Thank you. Thank you, Dr. Foley. Thank you, everyone, for being here, and thank you, AST, for the opportunity to talk about molecular diagnostics and artificial intelligence today. We'll spend the first half of this hour and 15 minutes below the diaphragm, and then we'll move above the diaphragm after that. We'll be talking about, we recently celebrated 5-year anniversary of AlloSure, and our patients and the field has been so blessed with all this innovation coming into the field in the last 5 years. And we'll be talking about where we are now, what we do in 2023 and beyond. At CareDx, we have put in significant innovation in multimodality and artificial intelligence, but we want to understand from our distinguished panel here what it means for the patient and their clinical practice. So the session will include data and science, but we'll keep it close to the patient. To introduce the speakers, I would want to welcome Dr. Srinivas, who's the Senior Vice President with CareDx. He's been with transplant for the past 30 years and has done a lot of research in all different fields, but it's best known for big data and artificial intelligence and how it relates to patient. So Srini, do you want to take it from here?
Thank you, Nikhil. Thank you all for coming in early in the morning for this breakfast symposium. Absolutely delighted to host you here, and we have a fantastic stream of speakers here. Dr. Anand will be speaking on behalf of Intermountain on the evolving clinical utility of AlloSure surveillance, and after that it'll be Dr. Ackerlin speaking about gene expression and molecular profiling, and I'll be speaking about molecular diagnostics and artificial intelligence in kidney transplant. Here's who we are. CareDx is your partner in transplant care. We do nothing but transplant. We live, breathe, and do transplant, as do you, as members of the AST and practitioners of transplant. And we thank you for your work that makes the transplant community what it is. Our vision is to be the leading partner for transplant patients in the transplant ecosystem. We realize that it's not just programs, it's not just patients, it's an ecosystem that enables transplant. And our mission is that we're committed to improving transplant outcomes by continuously innovating and providing intelligent solutions that are relevant throughout the transplant journey. I'm not going to go through each item here, but as you can see, we're involved in every phase of transplantation across all organs. Dialysis is shown, kidney is shown as an example, but we have similar buildups for everything from pre-transplant to wait listing to intra-transplant and post-transplant care with innovative solutions all the way, including pharmacy solutions and therapeutic adherence solutions. Without further ado, I'm going to introduce the first speaker, Dr. Sanjeev Anand, who is the medical director of the Living Donor Kidney Program at Intermountain Medical Center in Utah. Dr. Anand is one of the most innovative young nephrologists that I've had the privilege of working with him. I had the privilege of building the program at Intermountain with him. Delighted to welcome him as a speaker for us today in the symposium. Dr. Anand will be speaking about the evolving clinical utility of molecular solutions. Yeah, sorry. Oh, I'm sorry. Sanjeev.
Good morning, everyone. Today, I will be speaking about evolving clinical utility of AlloSure surveillance. So my financial disclosures are I'm a speaker for CareDx. So AlloSure kidney, these are some of the bullet points that I wanted just to go over. It targets all the somatic chromosomes and all the SNPs, and it's the only donor-derived cell-free DNA that has been validated for surveillance and it has long-term data with a 2 to 3 year follow-up, and it's a broad utility for many patients, and it's covered by Medicare when the coverage criteria is met. So first and foremost, when we started back in 2017 with donor-derived cell-free DNA, it's very important to see how it outperforms what we have and what we had. So over here, in the dark blue is donor-derived cell-free DNA or AlloSure, and on this green is your DSA. So for any rejection, you can see that AlloSure outperforms donor-derived DSA and serum creatinine, as well as for AMR, you can see that it has a really good area under the curve. So with that introduction, I'm going to now deep dive into some of the literature and how the literature has evolved over time. So this is kind of the historical background of AlloSure. So this is DOT study in 2017, which basically said that AlloSure outperforms serum creatinine, and AlloSure identifies rejection at 1% threshold. And it also gives you a high negative predictive value when the AlloSure level is low. And then came in, the next paper was by Bromberg, and what specifically was looked at was what is the biological variation in AlloSure, and it was found that it's less than 61% is biological variation. And I'm going to go into the next few slides about showing a clinical case about what it really means with that biological variation. And when you cross that biological variation, what really happens? And then later came, your RADAR study. This was by Eric Stites. And what specifically was looked at was at a threshold of 0.5%, can we identify individuals who are at high risk of developing subclinical rejection, who are at high risk of developing de novo DSA? And then came the Admiral study, and this was 7 centers, multi-center study, about 1,000 patients, and we had a 3-year follow-up. And it also showed that AlloSure is able to diagnose rejection both for surveillance and for cause, as well as AlloSure was able to identify donor-derived or de novo DSA a median of 90 days prior to it being detected. So coming into Admiral study, as I said, it's a longitudinal surveillance over 3 years. It was a multi-center, 7-center study, about 1,100 patients, 4,000 AlloSure visits, a median of about 6 AlloSure visits per patient, and patients were monitored for 3 years. So really long, longitudinal, surveillance data of AlloSure. And this was the first study and a really pivotal study, which I think has changed, our practice pattern quite a bit. So on this first slide, what I want to do is I want to focus right over here. You can see biopsy type for cause surveillance. And if you had no rejection, so these were centers that were doing biopsy for cause, and these were centers that were doing biopsy as a surveillance. And AlloSure was done on both of these. As you can see, if you had no rejection, then your AlloSure level was similar. And then in TCMR, you can see that it was higher. Of course, for surveillance, it was a little lower, but it was able to identify subclinical rejection, and that was the emphasis of this data. And then in AMR, you can see that it was elevated for both subgroups. So what the message was that it can identify, both subclinical and clinical rejection, meaning in surveillance also it was able to identify subclinical rejection, and it was hand in hand with what you were seeing when you were doing a surveillance biopsy. But again, the important point is if you had a low value, then you have a really high negative predictive value, and that is a peace of mind. And then this data, again, as I mentioned before, this is where AlloSure rose a median of about 90 days prior to detection of donor-derived or de novo DSA in the blood. And in this gray bar are patients who are AlloSure greater than 0.5%, and in the red bar are less than 0.5%. And as you can see, the probability of patients having de novo DSA was higher in this subgroup. And next is, did AlloSure correlate with eGFR decline? So if you had a higher AlloSure, does that correlate with eGFR decline? So on the x-axis here is your AlloSure level, and here is the eGFR. As you can see, if you have a low AlloSure or less than 0.5, pretty much your eGFR is scattered around this area. And as your AlloSure progresses, your eGFR is lower, and which showed that basically over time, if you have patients who have high AlloSure or high molecular marker of injury going on, that translates into loss of allograft function. And then this is where this relative change value, I want to spend some time over here, is that, as you can see, this is in the Bromberg paper, it identified that if you're less than 61%, then that's a biological variation. When you go from 61 to 150 or 149%, that exceeds your biological variation, and that can be the onset of molecular injury. Once you are greater than 50%, then it's a high likelihood that you're dealing with molecular injury. And in the right clinical scenario, most of the time we encounter rejection. So this was all the data for AlloSure, which was done in clinical trials. Now I'm going to change, and we're going to get into specific papers that has been done by individual institutions and authors. So this is from Cedars-Sinai group from Stan Jordan. And what it basically shows is that you have a high risk of ABMR in DSA positive individual if you have a high AlloSure. So if there is a patient who has a high AlloSure and you have DSA positivity, more than likelihood that you're dealing with AMR. And then this one is very interesting in the sense that over here on the left side, you have AlloSure less than 0.5, and then you have AlloSure greater than 0.5. And what it shows is that what is the percentage change in eGFR over time. So if you have a AlloSure that is greater than 0.5, then you have a higher likelihood of an eGFR change or a decline. And that, again, is, from the previous papers, as we have seen, reemphasizes the message that if you have a high AlloSure, that means that there is ongoing molecular injury, and which translates into loss of allograft function. And over here is these two columns is low AlloSure and high AlloSure. And you can see the cutoff was at 0.5%. And what it says is that the presence of DNA, DSA, and then the likelihood of rejection, you can see when it's greater than 0.5%, the risk is higher. So now, we have a molecular marker that we know if it's elevated, that's going to show molecular injury, and in the right clinical scenario, it could be, we most likely are dealing with rejection. Of course, if it's a much higher value and you have DSA positivity, then you're dealing with AMR, and then if you have a value which is greater than 0.5, most likely you might be dealing with TCMR. That's good, but then when we treat patients, does the molecular marker change? Does AlloSure change? And this paper really, pointed towards that. So what we see here is that these are patients who are called treatment responders, and these are patients who are called non-responders. And this is histological and molecular microscope data. So you can see in histology, these are the I plus G plus PTC scores, and you can see pre and post treatment. So these are treatment responders. The scores went down, the molecular microscope score went down, and for non-responders, the score did not, there was not a significant p-value. Now what really happens if we were to use AlloSure data in the same patients? So you can see right over there, you can see in the non-responders, you can see that the cell-free DNA went down, and over here, just as a comparison, is your GFR. You can see that the GFR really was not significantly different, but you can see AlloSure went significantly down in these patients who responded to treatment. In non-responders, it did not go down. And that, again, brings a really important utility of this assay, is that not only it helps you to diagnose subclinical, clinical rejection, but what it also does is that it also helps you to monitor the treatment response, and thus maybe taking away the need for follow-up biopsy. Now, this is a case series that looked at specifically AlloSure as an immune dial. Can we lower immunosuppression in certain individuals who really need immunosuppression to be lowered, secondary to clinical condition? And you can see that there's, cases. And then they went off MMF, was purely on belatacept. They measured pre and post AlloSure data in these patients. What I'm going to do is that these were case series, but it's always good if you have your own cases. So we have few cases that I wanted to share. So this first one is a 30-year-old female who had a living donor, living-related kidney transplant from her brother. And the primary cause for kidney disease was ATN and severe sepsis. She was a CPRA 0 and got a 0 HLA mismatched kidney. Now, what happened is that 2 years into the diagnosis, she got a diagnosis of melanocytic melanoma stage 1 without any lymph node involvement. You know it's bad when the dermatologist calls you and really is thinking that this is all related secondary to immunosuppression. So then, fortunately enough, she was induced with Similac because of 0 HLA mismatch. But then what we did was at the first time of diagnosis, we converted her from MMF to everolimus. So she was maintained on TAC, everolimus, and prednisone. But the goal was ultimately to see if we can taper her off everolimus completely or not. So what we did was that we used AlloSure for our favor. So you can see this is the AlloSure data right here in the blue. And then this is the tacrolimus levels, and this is the serum creatinine in the black. And what we did was that this is right here when melanoma was diagnosed, and we stopped her everolimus, we put TAC at a goal of 4 to 6, and we continued prednisone. And this is data from January of this year, and you can see AlloSure remains low, and the serum creatinine and tacrolimus goals you can see. But that is really encouraging that this was used as an immune dial. Now, in the old times, prior to as a biomarker as AlloSure, we would rely on serum creatinine. But as you have seen from DOT study, that serum creatinine is really like a flip of a coin. It has the AUC of 0.5 or 0.6. So next I want to go to the second case. This is a 50-year-old male who got DCD, deceased donor kidney transplant, end-stage renal disease secondary to polycystic kidney disease. Those were some of the transplant data. But this it was a deceased donor kidney transplant. So this was a 8 HLA mismatch out of the 12 that we do. And then what we did was further in this individual was we also at our center look at the high resolution gene, assay, and we typed his eplet, and we found that he's a low-risk eplet. He had only 4 mismatches as DR and 7 mismatches at DQ. And he was induced with thymo at 3 milligram per kg. So what happened is he got a lot of adverse effects from prednisone, weight gain, and he got, almost pre-diabetes, and then he had a lot of adverse effects from MMF. He could not tolerate it despite changing to myfortic and all that. So we decided we're going to stop prednisone on this individual, and then we're going to change him to Imuran. So this is where we had the intervention done, and you can see this is the AlloSure pre, and this is post, and this is his tacrolimus goal, which was maintained at 5 to 7, and MMF that was changed to Imuran. And you can see by utilizing AlloSure, we were able to put it like an immune dial and see how he did post-intervention. And he was stable, and again, the mismatch helped us in our favor. But to get to the point is that AlloSure can be used as an immune dial also in these patients when you're making interventions to make sure that AlloSure doesn't go up and they're not at high risk for subclinical rejection. And to end, I will put this slide over there, and this is a very nice slide. You can see on this x-axis is basically looking at what is your molecular injury pattern like. So back in 2017, we were over here. What we were seeing was we were seeing patients with EGFR decline. We were seeing with de novo DSA. We were seeing proteinuria. And the challenge was that it's too late to do anything. Most of the time when you do intervention, the horse is out of the barn, and it's hard to get a good allograft survival. Now we are here. We are here where we are looking at molecular patterns of injury. So we are looking at donor-derived cell-free DNA in form of AlloSure, and the next speakers are going to touch about Euromap and the gene expression profile. And what it does is that it puts us at a diagnosis much earlier, and where, if you do an intervention as we saw from responder versus non-responders, that you can most likely intervene early and would lead to successful graft outcome over time. With that, I'll hand over to Dr. Eckeley.
Thank you, Dr. Anand. You set the stage really beautifully for the next presenter, who will be speaking about the molecular presentations interrogated using gene expression profiling. It's my pleasure and honor to introduce Dr. Enver Ackelen. Oh, am I? Am I the one who's speaking next? Okay, I'm sorry. So I guess I'm speaking, so I'll introduce myself. My name is Titesh Srinivas. I'm a Senior Vice President for Medical Affairs and Clinical Operations at CareDx, and member of the transplant community and a card-carrying AST member for quite a long time. And had the pleasure of working with several of you in an academic setting. And where I'll be talking to you now is about taking the insights that Dr. Anand showed you and translating that into how we can actually make that happen with unfailing regularity in practice, and allowing you to use AlloSure in the context of all the other data that you accumulate in practice. So the challenges in kidney transplant, as we know, are that despite our declining acute rejection rates, long-term outcomes of kidney transplants have not improved significantly. We do have the occasional paper come out saying that they have improved somewhat, but for the most part, they're improved a lot less than we want them to improve. So the primary endpoint of many clinical trials, which is eGFR, is a lagging indicator of allograft injury. So at the same time, as we practice, is somebody trying to give me a clue? Okay. Closer to the microphone? Okay, sorry. Can you hear me better now? Okay, all right. One of the things here is that we have more biomarkers as we have more data in the setting of our electronic world. The abundance of data is sometimes a double-edged sword. And clinical decision making becomes really difficult, and sometimes the data actually works against you because it interferes with your time, and it takes effort and resources. So data not managed properly can lead to inefficiency. And the other problem that we have is that when we walk into a clinic, we think that we have a game on for every patient, and we think that we're going to take all the data into consideration with unfailing regularity and provide the same kind of care for every patient. So there's two problems. Now, one is our problem with the ability to integrate all the pieces of information. The second is to not deviate from ideal process. So technology provides an opportunity for insight. So we postulated that combining biomarkers and algorithmic intelligence in the EHR could allow timely personalization of care through automated biological insights and help avoid allograft dysfunction. So we embarked on a study in collaboration and a program of development in collaboration with the Paris Transplant Group, where up to 2,335 patients in total between 2013 and 2022 have been studied. Includes a French retrospective cohort, a French prospective cohort, and a US validation cohort, all totaling up to 2,335 plus patients, who underwent interrogation of all the clinical parameters that you want, in addition to AlloSure's donor-derived cell-free DNA. The whole idea was to see if we could predict who would have rejection on a biopsy using AlloSure in conjunction with clinically important parameters. In a multivariate model, what stood out was that AlloSure was an important independent predictor of allograft rejection. And when combined with all the other clinical information, such as a change in serum creatinine and donor-specific antibody, the AUC of the model was in excess of 0.8. So what we've done at CareDx is to provide a an opportunity for you to use this in your clinics in the context of our electronic health records to provide a rejection risk assessment of the allograft using AI-driven analytics, essentially a logistic regression model that incorporates donor-derived cell-free DNA, a change in serum creatinine, donor-specific antibody, a prior history of rejection, and allows you to aggregate these parameters with unfailing regularity in every patient that you see, and helps clinicians evaluate the management options for allograft dysfunction and decide who you want to do a biopsy on. We also help you integrate that with the iBox long-term prognosis so that you're able to sort out what you want to do with that patient that day in clinic, as well as answer that question that every patient has is how long is my graft going to last? So in summary, the allograft risk assessment that we have has AlloSure as an input, creatinine increments, eGFRs at baseline, prior rejection, and DSA, immunodominant DSA as the primary inputs. And output is an allograft rejection risk assessment, which is the probability of rejection in the allograft. So I'll lead you through a couple of cases. The first case is that of the slide's animated, and you can see how that works in real life. A 35-year-old female patient, 3 months after transplant, underwent a protocol biopsy. The kidney graft was stable. Creatinine was 1.85, low eGFR of 31 ml per minute, no proteinuria, and an anti-HLA DSA class 1 was 1647. Cell-free DNA is 0.12. These values are relatively modest. And the biopsy results, as you may expect, are normal. And the probability of rejection, as you saw, was 2.7%. The second case is that of a 74-year-old male patient. 6 months post-transplant, graft was unstable, as reflected by an increase in creatinine. Modest HLA antibody, cell-free DNA not really that high, yields a probability of rejection of 67.8%. And when you actually go back and look at the scores in this patient, the biopsies was a TCMR with an I3, T3, I3 lesion score. So that's essentially what would be available through the AI kidney product. We are about to embark on a study to study this prospectively in the US. And in summary, the AI kidney product that we have combines AlloSure with algorithms and data analytics that helps enhance clinical decision making, and the promise of integrating molecular biomarkers into models improves their performance. And this is the promise that we bring to you in the context of AlloSure. It is now my privilege to do this properly and introduce Dr. Enver Akelin as our next speaker. Dr. Akelin is the medical director of kidney and pancreas transplantation at Montefiore Medical Center in the Bronx, New York. Dr. Akelin has previously served a very illustrious career at Mount Sinai prior to coming there, having been trained in Boston. He's had continuous extramural funding for his research and is a well-known member of the transplant community and an editor at several important transplant journals. He's always been an out-of-the-box innovative thinker, and we are privileged to work with him at CareDx on his work on incorporating gene expression profiling into molecular surveillance for kidney transplantation. Dr. Akelin, thank you.
Thank you very much, Srini. Good morning, dear colleagues. I would like to cover the gene expression profiling of the patients. So this is my financial disclosure. So far we learned about and heard about the cell-free DNA, which is a marker for the allograft injury. And any allograft injury can increase the cell-free DNA level. So the next question is, do we have the markers that shows the immune activity in kidney transplant patients? So as you know, the autoimmune response does not start at the kidney, but at the secondary lymphoid organs. And it augments, and then the activation of immune cells started first in the peripheral blood. And the next stage, it goes to the the tissue and initiates the cellular infiltration, tissue inflammation. So you can find this at the time of protocol biopsy. But most clinical scenario, so we found when the creatinine is increased, patient develop with donor-specific antibody, we do clinical indicated biopsy and found out rejection. So how we can able to find the increase immune activity or immune quiescence before the rejection happens? So first, I go to the AlloMap kidney. Briefly with one slide, we need to talk about the AlloMap heart, which you will see, and here, the next part of the symposium. And it was started in early 2000 because, as you know, the heart transplant team, they always do frequent protocol biopsies once a week and then every other week. So it was important to find out if there is any biomarker that can avoid the protocol biopsy. And the initial cargo studies published in early 2000, and then the image study which was published at New England Journal of Medicine demonstrated the non-inferiority of clinical outcomes in patients with AlloMap surveillance compared to patients with biopsy surveillance. And after this New England Journal of Medicine paper, the International Society of Heart and Lung Transplantation that recommended that the AlloMap heart can be used as a non-invasive method for ruling out moderate to severe rejection, and it was the only biomarker approved by the FDA right now. So the aim that the study, which was recently published at the Kidney 360, if any of those 11 gene transcripts in AlloMap heart is also associated to differentiate the rejection to immune quiescence in the kidney transplant patients. And then the DART study patients, the data, the blood samples used for this analysis. And at this study, it was found out that 5 out of the 11 AlloMap heart has the best statistical significance to differentiate the rejection and immune quiescence in kidney transplant patients. So briefly, when you look at these 5 genes, the program cell death, the PDCD1 is important, T cell priming, and then the March18 and DKF12 is important, proliferation and mobilization of the cell. IL-1 receptor and FLT3 steroid responsive genes. So when we look at the two different groups, the rejection patients have significantly higher AlloMap score compared to immune quiescent patients. So what are the immune quiescent patients? That there were 3 groups. One group is clinically stable, creatinine normal, AlloSure levels are normal. So it was significantly higher. Or patients underwent protocol biopsy and there was no rejection. There was another group. And the other group is the clinical indicated biopsy, but the biopsy was normal, there was no rejection. So when you look at it, these 3 questions is significantly lower than the rejection patients, whether it is T-cell mediated, antibody mediated rejection. And here at this study, like even the T-cell mediated rejection was the higher. And it gives the prediction as the AUC value of the 0.78. And then we compare what happened to all the patients with the AlloSure levels. So let's see the cutoff value of the 11.5 for the AlloMap, and then the AlloSure at 1, and when we decrease to 0.5, but these 2 cutoff 0.5 and 11.5, you will just identify all the rejection patients other than one biopsy, which was borderline and it wasn't clear. So by adding the AlloSure, the AUC values slightly increased to 0.89. So definitely, these are still the small number of the patients, and more complex methods might improve the outcome. So this was the second study about the AlloMap kidney, it also recently published. It's a prospective multicenter OKRA study of 235 patients, 66 rejection and 169 quiescent specimens. And the AUC value was the similar, 0.78. And at this paper, the other is the how repetitive than the method. So it was like done by different operators. It was repeated at different time points. So it was a very good accuracy correlation coefficient of 0.99 and then the low standard deviation of the scores. So this is the show these two studies, the first study and the second study. So at this, the first study at the Kidney 360 paper, the 11.5 has the highest specificity and the sensitivity, and had a positive predictive value of 23% at the 10% prevalence of rejection. So in routine monitoring of our patients, we see mostly around 10% rejection. The rejection increases 25% in clinical indicated biopsies and the patients had worsening kidney function. But the negative predictive value increases in 25% prevalence to discriminate rejection from quiescence, and the PPV is 48% and negative predictive value 87.2. And at the second paper, the similar that the 10% prevalence of rejection, negative predictive value 95% and 87% in the 25% prevalence of the rejection. So these are important that when you get the result, you need to look at the positive predictive and the negative predictive value to interpret the result. So the plan is to give the AlloMap result just with the score, but at the same time, at each score, what is the positive and the negative predictive value that the clinicians decide how to interpret the result. So the last few slides talk about the Euromap. As you know, that Dr. Slendran from Cornell has been working on the urinary biomarkers for the detection of the rejection. And as you know, the CEoT 4 study, which is NIH-sponsored, prospective, multi-center trial, 4,300 urine samples from 485 patients, that the three gene signatures, CD3, mRNA, IP10 and 18S RNA, which is 18S RNA is the housekeeping gene, definitely discriminates the acute cellular rejection from non-rejection, and with the AUC of 0.85. And the other interesting point is not only to differentiate, but also that it can detect 20 days before the biopsy, and also it can show the response to the treatment as well. The other point is, as you know, the kidney transplant patients, 30 to 40% shed BK virus in the urine, 10-15% in the blood, and the BK virus nephropathy might increase the gene expression profiles in the kidney as well as in the urine. And even sometimes the biopsy may not differentiate if it is T-cell-mediated rejection or the BK virus nephropathy. So these are also from the Cornell Group 3 studies to look at the BK virus VP1 mRNA, and with the threshold of 6.5, they can differentiate if there was a BK virus nephropathy or not. Also, the Euromap incorporates the 3 signature with the BK virus. And so this is the signature that Darshana Dadani, on behalf of the Cornell Group, presented at the American Transplant Congress, that the 58 biopsy match, urine and plasma specimens from 55 patients, 11 T-cell mediated, 10 AMR or mixed rejection compared to normal and AKI biopsies. So there was definitely the difference between the rejection and whether it is T-cell or antibody-mediated rejection in terms of the CEoT4 signature as well as the cell-free DNA. But the combining both methods significantly increased the accuracy of the test. So in summary, so the AlloMap kidney, UroMap AlloShare definitely contribute independent signals and inform on different aspects of allograft rejection, and especially UroMap can aid in differentiated BK virus nephropathy, and multimodality molecular tools provide a holistic view of allograft health and improve diagnostic performance with combining AlloSure AlloMap with the AUC of 0.89 and UroMap with AlloSure AUC of 0.92. Thank you very much for your attention.
Thank you so much, Dr. Ackland. So we only have a few minutes left. We want to understand from the audience as to how you think the artificial intelligence tool that Dr. Srinivas talked about and gene expression profiling that Dr. Ackland talked about, how do you think it will be incorporated in clinical practice? You know, in the last 5 years, AlloSure has brought us to a point where thousands and thousands of patients have benefited from it. And as we bring these tools to the clinic, we want to see how it will impact the decision-making beyond AlloSure. So if you can bring out your cameras, please, and scan this QR code and answer this question for us. So incorporating artificial intelligence will enhance your interpretation of molecular diagnostic data and select all that apply. Is it when you're suspecting subclinical rejection? Is it in patients with borderline molecular test results, in patients with discordant diagnostic test results, or when you're suspecting clinical rejection? And while we wait for the audience, if I can ask Dr. Anand, who has extensive experience in using AlloSure in his practice, where do you see AI kidney and artificial intelligence helping you out and your patients?
Yeah, so if I could, rank order them, then I think, it's when I suspect subclinical rejection, then I think, AI is going to really enhance my interpretation. I think that would be the one area that I would like, AI to be able to enhance my clinical thing. I don't know if Dr. Ekelin, you have anything to add.
So I agree, especially the slide by the Srini was very impressive. I do not think that there is only one test will give you a 99% positive, 99% negative predictive value. So we need to cover the different aspects of the patient, from the gene expression profiling to the injury scores, donor-specific antibody, creatinine level. So I believe that it will significantly improve to combine all these tests with the AI, I believe.
Awesome, thank you. So I have the polling results on my phone here. For some reason, it's not showing up on the screen, but it looks like the audience is really split. 31% think it will be most useful when suspecting clinical rejection. About 25% each think in patients with borderline molecular test results and with discordant diagnostic test results, and another 18 when suspecting clinical rejection. Next quick question, and then I promise I'll hand over to my colleagues above the diaphragm. So in your clinical practice, how do you see combining gene expression and donor-derived cell-free DNA will be useful? And please select all that apply, not just one option. And I will start that question with you, Dr. Ackland. If you can rank order, where do you see the most utility of gene expression when you combine it with AlloSure?
So I think that so far, when we look at all the studies that use the cell-free DNA and then the gene expression profile, I think the negative predictive value is significantly high. I think I would first rank the immune quiescence is more reliable due to positive predictive value still changes from 25% up to 86% if the patient has donor-specific antibody, and the prediction of the rejection probably might be less than the immune quiescence. But still, we do not have any study to combine all these result, gene expression, AlloSure, AlloMap, UroMap with AI. Then definitely the looks like the positive predictive value will significantly increase. At that time, I believe that the subclinical rejection will be more important in diagnosis. And then the other is the undergoing immunosuppression changed. For example, BK viremia, we decreased the immunosuppression, and now we have more problem with the development of donor-specific antibody and rejection than BK virus nephropathy. Like when it is safe, they continue to decrease the immunosuppression, and I believe this will be a very important in management of immunosuppression to use all these modalities.
Excellent. Well, thank you so much. Again, the audience poll is not showing up on the screen, but I can read it out from the phone. So option B, ruling out clinical rejection and need for biopsy seems to be the choice here, 33%, followed by option C, in patients who are undergoing immunosuppression changes. And A and DS are both at 19%, so in surveillance for subclinical rejection in patients with borderline test results. Excellent. So I would really want to thank the panel here. For your insights, and hope that as we bring artificial intelligence and multimodality to the clinic, it will really enhance what we can do today.
Thank you so much.
Awesome. Thank you.
With that, we'll expel the abdominal contents and welcome some fresh air and fresh blood onto the stage. Thanks.
Good morning, everybody. My name is Jeremy Kavolnik. I'm the medical director for heart transplant for CareDx, and we'll be doing an interactive case presentation on an interesting a patient with a heart transplant in conjunction with Dr. Sean Pinney. Dr. Pinney is a professor of medicine and an expert clinician and researcher currently at University of Chicago, but shortly moving to Mount Sinai Hospital. And so he'll be joining me as the case discussant as we go through this. These are his disclosures. So I'll start with the case. We've entitled it "Shooting in the Dark," which will become, which will mean something in a few minutes. 28-year-old male with known hypertrophic cardiomyopathy who received an initial transplant at the age of 10 years old. He ultimately developed ISHLT CAV3 and listed for retransplant. He was highly sensitized, not unexpectedly, with the CPRA of 90%. He received preoperative desensitization with plasmapheresis and rituximab. He had an uneventful transplant with a negative virtual cross match, did receive induction, and was started on usual triple therapy for immunosuppressants. His early biopsies were reassuring with normal cell-free DNA and gene expression profiling, no donor-specific antibodies, and normal graft function. So at 5 months post-retransplant, he had a routine clinic visit where he was asymptomatic. He was at least jogging on the treadmill. He had no donor-specific antibodies. His echocardiogram remained normal. His tacrolimus was at 3 twice a day with a trough level of 6. His MMS was 1 gram twice a day. He remained on prednisone that had just been recently decreased 1 month earlier. And these are his HeartCare results with an AlloMap score of 38, previously 30, and an AlloSure that was now at 0.15%, previously at levels that were undetectable. So the question that I'll now ask Dr. Pinney is how would you interpret the results of his molecular diagnostics? Would you trust the AlloSure and ignore the AlloMap, continue weaning the steroids, proceed with a biopsy immediately, check a CMV PCR and repeat HeartCare in 2 weeks to assure that this does not represent any early cellular rejection with no change in therapy currently? Or since there's no right answer, ask your fellow what they would do and praise them for their well-reasoned answer. Thank you for laughing this early in the morning. Dr. Pinney.
Thanks, Jeremy. This is a great case. Can you all hear me? I don't know if this microphone is on.
Closer.
A little closer. Is that better? Yeah, that sounds better. So I think there are a couple ways to approach this. One way is to start with the patient, and the patient is a high-risk patient, highly allosensitized or retransplant. The prograph level, the tacrolimus level, was maybe a little bit on the low side. And we saw that significant bump up in the AlloMap score up to 38, which has a pretty high predictive value for creating suspicion for T-cell mediated rejection. On the other hand, we hear that he's asymptomatic, exercising, normal echo, no DSAs, And even though there was a slight increase in the AlloSure result, we know from some work at Cedars-Sinai that patients who are allo-sensitized have a higher baseline AlloSure level, right around this level, 0.15 or 0.16. And in our own center, we use a threshold value of 0.2% to decide whether or not to proceed with a biopsy. Plus, we also know that there are other reasons to have an elevated AlloMap. In particular, CMV disease can increase the AlloMap score. So I think you could go either way. I think in our own center, what we would do is we would repeat the test in 2 weeks because we would have still that background suspicion for rejection. We would also look to see whether or not there was a detectable CMV PCR level. And if the results remain the same or if they are higher, then we would go ahead and proceed with a biopsy at that point.
Thank you. Dr. Pinney nicely highlighted some of the options and how to use our tests, which are complementary tests. This is a quick reference guide that I won't go through in detail, but it gives some instructions of things to consider in that high AlloMap, low AlloSure category, where early rejection and active CMV should both be considerations. The patient, as mentioned, had a follow-up 2 weeks later. The AlloMap remained elevated at 38. CMV PCR was negative. The repeat AlloSure increased from 0.15% to 0.2%, and a biopsy was ultimately performed, which revealed to our cellular rejection with normal hemodynamics and was treated with pulse steroids and with biopsy-proven resolution of the rejection. So I think this is an excellent example of how to use our complementary testing. Also, incidentally, in line with the recently released guidelines that now include the use of AlloMap before 6 months based on the e-image study. So I'll fast forward. The patient remained clinically well, immunologically quiescent. The patient returned for an 18 months post-retransplant visit. He was asymptomatic. He's now playing golf, ideally in Arizona with a little bit warmer weather. He remained with a normal echocardiogram, a normal one-year angiogram with ISHLT CAV 0. He was on, at this point, TAC 2 twice a day with trough levels of 5. The MMF is 1 gram twice a day, and he's now been successfully weaned off the prednisone. He has no donor-specific antibodies currently. His AlloMap comes back at 31, and his AlloSure comes at 0.25%, which was higher than his previously measured value at 15 months post-transplant. You can see that in the graphs on the right. So the questions for Dr. Pinney, which is at this point post-transplant, well into his second year, which surveillance strategy, if any, would you follow this patient at this time? And then what would you do for this patient with these results?
So it's a great question. I think this is a good example of using donor-derived cell-free DNA screening over the second year of transplant to assess the health of the allograft. I'm not as interested necessarily in looking at or screening for rejection, but I am interested in as to whether or not the allograft is being injured. And at that 0.25%, I am concerned that there may be some allograft injury. And so I would look a little bit further. And I think we heard that there were no donor-specific antibodies, and the angiogram was negative, but we didn't hear whether or not there was IVUS, so I might do an IVUS to look to see whether or not there is evidence of graft vasculopathy. And I might also screen for non-HLA antibodies.
Perfect, thank you. So just moving forward, this patient ended up with a biopsy. The hemodynamics were normal. There was no evidence of rejection. What would you do at this point? And I think you've alluded to some of the other testing, so I'll just fast forward a little bit. The patient 8 weeks later remained asymptomatic. Repeat testing showed no donor-specific antibodies. The AlloMap was 33, and the AlloSure continued to increase from 0.25 to 0.6%, as shown in the graph over here. And the question is, what would you do at this point?
Well, I'm worried at this point because to me this means that the allograft is continuously being injured. So the things that obviously come to mind, antibody-mediated rejection, and even though there are no donor-specific antibodies, no HLA donor-specific antibodies, I'd look for the non-HLA antibodies. I would look and screen a little bit more carefully for graft vasculopathy. And I think the other test I would consider doing would be a cardiac MRI. The last thing I would do is, I would if we have a biopsy sample, I would do a molecular microscope and see whether or not that points me in a direction that might be either allograft rejection versus allograft injury.
Perfect. So this patient had another biopsy, again, that continued to show no evidence of ACR and AMR. We talked a little bit about your approach for patients with persistently elevated levels and some of the testing that you would consider. So just for the interest of time, we'll skip to this slide, which I'd like to point out comes from a relatively new publication from JACC Heart Failure from the Women in Heart Transplant Consortium that specifically highlights some of the diagnostic considerations that Dr. Pinney alluded to in patients who have persistently elevated donor-derived cell-free DNA in the absence of biopsy-proven rejection, including some of the advanced testing, non-HLA DSA testing, molecular microscope, and advanced imaging testing. So we'll just quickly go through the postscript of this quite interesting case. The molecular microscope in this instance showed no evidence of injury or rejection. The repeat coronary angiogram showed CAV 0, and the IVUS measured was abnormal but not dramatic at 0.7 millimeters MIT. The cardiac MRI was ordered but remained pending, and ultimately the patient presented 3 months later with clinical heart failure, new class 2 DSA with an MFI of 8,000. It was C1q negative. The AlloSure was now 3%, though the biopsy remained negative for ACR and AMR. This is his echocardiogram. You can see here quite thickened myocardium with very little motion of the base of the myocardium, and Doppler hemodynamics were consistent with a restrictive physiology. The patient ended up going on to get a cardiac MRI, which showed significant enhancement both the pericardium and epicardium, consistent with potential antibody-mediated rejection. So I think, Dr. Pinney, what would you do at this point, just coming to the end of this interesting case?
So at this point, I would treat for antibody-mediated rejection. And so I won't go into all the options that we have. I would start with plasmapheresis, IVIG, and rituximab as a first line of therapy for AMR.
So that's actually what happened with this patient. He was treated initially with plasmapheresis. His baseline immune suppression was increased. He ultimately received consolidation therapy with rituximab. The AlloSure improved, though did not normalize, at least initially, and his heart failure clinical syndrome improved as well. So just to end off, I'll just again point to this recent state-of-the-art paper from the Women in Transplant Consortium, excellent practical guide to use molecular diagnostics in the surveillance of patients post-heart transplant. An excellent read for those of you who haven't seen it yet. And then I'll just quickly ask for some feedback. If you can scan the QR codes just to help us plan future symposiums, this would be very helpful.
Can I vote?
Absolutely. All right, and we'll go to the next one, other question. And with that, I will end and invite next speaker up. Thank you. Dr. Wang, thank you.
Can you stay up or do we go up?
Great, thank you for the invitation to speak. Everybody hear me okay? I guess I'll introduce myself. I'm the medical director of lung transplant at Houston Methodist, and I've been invited to give a brief talk on a few cases where we use AlloSure Lung as kind of a decision support tool. My disclosures. Okay, so we're going to go right into the cases. I'm going to talk quickly and hopefully wrap up on time. Our first case is a 61-year-old male. He was had COVID ARDS and was bridged to double lung transplant after 118 days with VV ECMO. And he had a CMV mismatch. He had kind of pretty standard comorbidities. Hypertension and chronic kidney disease, OSA, gastroesophageal reflux disease, had some gastroparesis after the procedure. Was actually doing quite well. He did develop some DSA about 14 months after the transplant. He was treated with IVIG infusions, and the DSA went away. Good graft function, doing well clinically. So he shows up to the clinic. This is about 19 months in, and has some has some sinus congestion, and had non-productive cough over the past week. One of his grandchildren had some URI symptoms. He was treated with oral antibiotics by his primary care provider, and we see a drop in his lung function from his baseline. So this is a chart of his lung function. It's depicted by FEV1 in the black dots, and the AlloSure is plotted in the red bars. And so when we saw him, there was a drop in his lung function. This is the 2.5, and subsequently AlloSure was drawn. We didn't have to biopsy him. His testing came back positive for RSV, so very sensitive modality to determine any insult to the graft. Subsequently, the graft function recovered, and interestingly, later on, he also had a rhinovirus infection. This didn't really impact his graft function. His AlloSure values remained low. So this is an example where, if you look at the change in FEV1, that's not the only thing that drives us to send somebody for a biopsy or for further testing. I think everything points towards kind of an infection, and we're going to monitor closely. Second case is a 78-year-old male. He is a single lung, and so for us, these single lung patients, obviously the lung function tests doesn't just, it's not a readout of just the graft function. And so it becomes much more complicated sometimes trying to figure out what's causing a loss in lung function. And so he's about 8.5 years out from a left single lung for IPF, actually doing quite well, very functional, and has no history of DSA, no history of acute rejection. He did have COVID, but it had a really mild clinical course. Stable dyspnea on exertion. And he came in for an annual evaluation and was found to have a new right upper lobe mass. This is in the native lung. So AlloSure is quite specific, right, so for the allograft. And so you can see a plot of his lung function trajectory over time. The AlloSure was low, and he did turn out to have a non-small cell lung cancer that's developed relatively quickly in the transplanted lung. So you can see from 1 year to the next, he developed this right upper lobe mass, very FDG avid. AlloSure was low, and so subsequently he underwent a resection of the right upper lobe. And we really didn't see any reason to not proceed because the right native lung only had 2% perfusion. He was not on oxygen. He was actually quite functional and actually did well after surgery. And you can see that the AlloSure values remain quite low, right? So specific for the allograft. So if the allograft was not functioning well, obviously we would have made probably a different decision. Last case is a 75-year-old female. She's about 19 months out from left single lung transplant for IPF. She's a CMV mismatch and had a lot of comorbidities, was quite frail, had a really difficult course afterwards. And she's one of these kind of older patients that has a difficulty tolerating the medical therapies and the prophylaxis, had frequent issues with leukopenia, multiple infectious complications. Actually had an episode of CMV viremia even with valganciclovir dose reduction due to problems with leukopenia. We had to really go down on her cell cycle inhibitor dosing. And so you can see there's several AlloSure results. So the first one was actually a very low result. And maybe she's on a little too much immunosuppression. Subsequently, she had problems with the CMV viremia that came after dose reduction in the valganciclovir. This was also coincident with an adenovirus infection. So this is when that AlloSure went way up. She was treated with antivirals, and CMV viremia went away, adenovirus infection resolved. Oh, okay. All right. I think I'm ahead of time, actually. So the viremia resolved. However, she came back short of breath. But you can see in the FEV1 is relatively flat when you look at that plot. And so there wasn't really a major loss in lung function. So what's going on? The patient's short of breath, AlloSure is high, the viremia is gone, right? And so I think this is where kind of this decision support utilization of this test comes in handy. So it turns out she had a PE. And you can see the 6-month post-transplant perfusion scan on the left, a very good-looking left allograft, receiving majority of the perfusion. And when she came back in short of breath, you can see these multiple perfusion defects in the graft. And she did have an acute PE. CT angiogram is on the right, and she actually underwent thrombectomy. So she actually underwent catheter-directed thrombolysis. So comes back to see us in the clinic a couple months later, and the shortness of breath has improved significantly, actually completely resolved. Lung function actually improved, and as a wrap up, actually I just got the AlloSure result, and it's less than 1 at this point. So this I think is a kind of good illustration of how having AlloSure gives us an extra tool to disambiguate these situations. And I think that's it. My third case. Happy to take questions afterwards. I think we're still on time, right?
Thank you, everybody. I think we'll take, as we're right at the end of the hour or the hour and 15 minutes, we'll take questions at front. If anybody has any questions, you can come up. Thank you, everyone, for coming, and enjoy the rest of the day. Hopefully some good weather for the rest of this conference.